I'll show you.
Did I connect?
And I'll show you too much space.
Good evening, Endo Summit Live, and welcome to our very first Tuesday edition of Endo Summit Live. We just had to have our next two guests, and to accommodate them, we are showing up on a Tuesday, and you are showing up in full force. I see you, Facebook. I see you, YouTube. I see you, LinkedIn. Everybody is logged on and ready. If you're looking to ask questions tonight, you should be in our audience over on our Zoom link. Please welcome from the Mayo Clinic, and they even managed to be in the same room, featuring the International Endometriosis Imaging Congress. We have Dr. Wendy Van Buren and Dr. Zarak Khan. Now, Dr. Khan, do you want to share with everybody a not so known fact of what makes you famous in this endometriosis crowd aside from your surgical skills? Where are you a graduate from?
I am with the CEC, of course. Dr. Finero
Right.
has been my mentor and just a wonderful guiding light for me in my career. So I think that a lot of people will relate to that.
So the most important thing is that Wendy Weiner, who of course is with the Center for Endometriosis Care, says you have the best skills of any fellow graduate they ever had. So we love having you on, and we love having your partner in crime, Dr. Wendy Van Buren, on. Go ahead and you guys can introduce yourself.
Absolutely. All right. Well, we do have a couple slides. So maybe when we do our introduction, I can show you because Zarak doesn't know yet, but I put some pictures in there of us. So
you can... I'm scared and excited at the same time. So I think we should be good here. And I'm just making sure that we're able to share, and then this would be the next.
Oh, you're able to share. We see you. We see you.
Oh, excellent. Awesome. All right. So today is fact or fiction. It's going to be a game. So we're going to get going. This is going to cover a lot of information, but in a really fun kind of way. So it's going to cover a lot of controversies in endometriosis that we hope by showing you pictures in the imaging, it's going to reveal some new information or perhaps solidify what you know already, and maybe it will bring up some new ideas. So only relevant disclosures are that I'm the founder of the International Endometriosis Imaging Congress. I'm very passionate about endometriosis imaging, as Zarak will attest to, and I do some lecturing and travel, and so does he. We won't discuss any off-label usages. Today, we're going to give a brief introduction of ourselves, then we're going to go over the fact or fiction cases, have some controversial discussions, and then have some question time after. So let me introduce you to Dr. Zarak Khan. So that's a picture of us in a parking lot in Rochester. Yes, even he and I can get glammed up for a parking lot situation. We have that capacity. And he's a super talented individual who's double fellowship trained in both REI and MIGS, and an incredible clinical partner for interdisciplinary work. And he's always pushing forward the boundaries of patient care and research and science, and really, phenomenal individual who also chairs the REI section here at Mayo Clinic. So, yeah. Now you.
And I'm going to introduce the wonderful Dr. Van Buren. So Dr. Van Buren is, of course, our board-certified radiologist that has subspecialized in ultrasound and abdominopelvic imaging as well as breast imaging. But more importantly, I think Wendy has been, or Dr. Van Buren has been the key driving person that keeps us all engaged, keeps us all enthusiastic about the work that we do every single day. And if I running joke almost always is, if I could take Wendy's enthusiasm and bottle it and just take a sip of it every now and then, I am going to be good moving forward. So we're incredibly blessed to have Dr. Van Buren as a part of our team and leading our team, and really also engaged in society research and also multidisciplinary collaborative research that really is putting imaging onto the forefront of endometriosis. And as we'll discuss today, we'll go over why it's so important. I think imaging is not only important for the patient, but is most important for the surgeon taking care of you and your entire multidisciplinary team. So hopefully after connecting and talking with us today, we can further reaffirm those beliefs for you guys.
And that picture was put there because we wear many different hats.
That's fair enough. I thought.
I am a very punny person, okay? So you have to bear with me today. And we're going to play a game. So these are the rules of the game. So you have to listen to the statement. We are going to have 10 statements. There is going to be a bonus point. So keep track of your own score. I can't do that for you. And then you have to decide if it's fact or if it's fiction. And then we're going to show you some radiology images. And then you have time to change your response. Remember, it's all just for you. And then intense debate is going to follow. All right. So fact number one, or fiction, is for you to decide. Superficial disease can't be seen on imaging. Fact or fiction? It's a really hard question. So I went big to start. Zarok, do you want to tell us about superficial endo on surgical?
Absolutely. So I think when I think about superficial endometriosis, I really do think it's one of the areas that is very challenging because it is something that can be hidden. And I won't give you the answer yet if it can be seen by imaging or not, but at least from a surgeon's perspective, it is really important for me to see surgical images from op note, not just op notes, but also images of surgery. Because one of the things that we do with our surgical trainees is really we go over multiple slides of is this endo or not, right? And I think that for those of us that are doing a lot of this every day, know that intraoperatively, your eye has to be trained to look for endometriosis as well, even if it's very minimal or superficial. Endo can hide very well in different nooks and crannies of the abdomen, not just the pelvis, but the mid or upper abdomen. And then also, endo has multiple faces. So if we look at juvenile endometriosis or people in their teenage, we will almost never see these powder burn lesions that are shown on the left, on the right in the slides here, but we might see more vesicular or basically very clear vesicle-like endometriosis, what I call baby endo to my trainees. And the one day that baby grows to become that powder burn lesion or that hemorrhagic lesion. And then there's, of course, variants. There's like the very wispy white fibrotic endometriosis that a lot of people will miss. And one of the things that I see, and I'm constantly surprised by this because we're continuing to teach even ourselves, is to whenever I take biopsies, I have a targeted map of each patient and I corroborate that with pathology to make sure that what I am doing, I can learn and understand on a daily basis too. And I would be lying to you if I told you that my hit rate is 100% at this point. I'm still removing suspicious areas that at the time of surgery, I'm like, this may not be endo, but I've talked to the patient that my mantra is when in doubt, I take it out. And so really, when the pathology comes back, sometimes I'm still shocked to see presence or sometimes absence of disease even in these very classic lesions. And so I still think that there's a lot to be said about superficial endometriosis, on who does your surgery, where they look, how experienced their eyes have been in looking at disease, and really trying to get that 100% kill rate and getting all the endometriosis out of the type of surgery.
All right, so that's a good preface that gives us a background of why superficial disease has the reputation that it does on imaging of not being apparent, because we're not talking about one type of thing. We're talking about many different presentations. So let's look at some examples. So this example here, this is called a T2 weighted image where fluid is bright. And the blue arrow is pointing at a little tiny fluid-filled cystic structure that's sitting at the back of the uterus, kind of near the right uterosacral ligament. And this is a form of superficial endometriosis that, is likely a small gland. So we can see it if it's filled with the fluid, it kind of stands out on the dark background. That's a pretty confident finding for endometriosis and fairly specific. Likewise, if we have the hemorrhage, which would probably correspond to those powder burn lesions, they can be kind of smooth and linear, but in areas where they don't belong, or focal kind of nodules or deposits. This one's on the ovarian serosa. This one here is on one of the uterosacral ligaments. So again, we're going to have a high degree of specificity, so being confident in superficial endometriosis diagnosis in these circumstances. Now, when does it get tricky? When we have like smooth thickening, and we apply an arbitrary number. So a lot of times in the literature, we have like 3 millimeters of thickening. Well, if there's no glands or hemorrhage with it, and there's still like normal variation that's possible. So unless you have some focal thickening or nodularity or some kind of change if it's a little bit wavy or undulating, such as this case, it becomes a little bit more equivocal. So that's where superficial disease can get tricky. And if it's all smooth thickening, then you really don't know if it's the whole uterine serosa and the urosacral ligaments. So part of that reporting comes down to communication with your surgical team and what do they want reported? Do they want to hear every single possible spot that might be involved, even though you're not sure about it? Or would they prefer you just report the areas that you're confident with? Or is it somewhere in between the two? So you can see that there are certain subtypes of superficial endometriosis that are quite well seen. This is an ultrasound example. So we can still see superficial endo on ultrasound occasionally, but particularly when there's free fluid. So such as this case, because otherwise it's kind of non-specific. Even in this case, it's non-specific. There's nothing about this that makes it look like a definitive endometriosis lesion. It could be some debris, and it was kind of like a little bit floaty in that region. I was scanning this patient. She was focally tender there. I knew she was going right to the OR. The other advantage is she was bowel prepped. So small lesions like this on ultrasound and non-bowel prepped, it would be like essentially zero chance. But she's bowel prepped. She's got the free fluid. It's all the perfect circumstance. And honestly, she didn't have any other endometriosis anywhere else. So it's a bit of an unusual circumstance there, but ultrasound, even lower sensitivity and specificity for superficial endometriosis. So at the end of the day, the answer is yes, it can be seen, but not all types of superficial endo. MR probably has definitely a higher degree of sensitivity or detection for it and specificity than ultrasound, but it all comes down to protocol and interpretation skills. So first of all, we'll talk about the protocol. And trust me, point number one for factor fiction is the longest. The other ones move a little faster, but this is the nitty gritty stuff. So we need to talk about this and get real, because if you don't have the right protocol, none of this is possible. These pipe dreams don't happen unless you go to the gym and do the work. You have to put in the fundamental effort to get your protocol where it needs to be able to see these types of findings. So the video that's playing on the right-hand side is without vaginal gel, without glucagon. There's a lot of motion, respiratory motion, bowel peristalsis on this scan, and it's hard to delineate that bowel invasive disease and the cervical invasion. The middle and the far left-hand image show you these hemorrhagic tracts invading the cervix really clearly. And when we've got the vaginal gel here, we can see the whole posterior vaginal fornix is invaded, and we see the bowel invasive disease a lot more clearly when that bowel motion isn't peristalsing anymore. So it's a lot easier to give the measurements and communicate to our surgical team what is going on exactly. So we published this back in 2020 as part of the Society for Abdominal Radiology Disease Focus Panel. Endometriosis is a group that I founded about 9 years ago now. And this is from our first special edition that we published. We're now preparing for our second. And within that first special edition, you'll find a standard protocol that is a consensus statement for protocol consideration. Our most recent publication, Dr. Khan and I were working on this together with a team of experts here in the Journal of Radiology. And so that has some updated report templating and protocol considerations and many different overviews for the disease spectrum, ultrasound through MR, and we'll give you a great overview to understanding the radiology aspect of the disease.
So I think before we even get to the second one, I'd like to sort of end on saying that what Dr. Van Buren is basically saying is I think the example of it that I give people is in order to write beautiful poetry, you have to know the grammar and the alphabet and know how to write sentences and have a strong foundation of the language in order to be very well, versed in it, either to write literature or poetry, right? And so all the beautiful things that we can do are based on that sound principle of we want standardization of how we look at imaging. How do we image people? So we're comparing apples to apples. We're not comparing different people with different protocols. We have a standard way and a template of describing that. And how that translates to us in the operating room it's wonderful, because I know that when a person has been read by Dr. Van Buren and her group, I know exactly what to look for, what areas and how they've described their report. And so to me, I've also now started looking at images before even reading the report and trying to educate myself in that. But really, I think having a standardized approach to sort of all disease processes and how you look at your imaging is really, really important.
All right. So we're gonna move a little quicker, so point number 2, endometriosis can't turn into cancer. sort of a controversial topic. And is that statement fact or is it fiction? All right. So this is an example of a 44-year-old female with pelvic pain. She has a multiloculated cystic mass in her right ovary that you see here. And the arrows are pointing to papillary or nodular projections in the ovary that show enhancement. This has gadolinium contrast. And that enhancement and this configuration is basically pathognomonic for malignancy. So I'm going to show you, and that means like it is until proven otherwise. That ovary has to come out. So now to show you the comparison, the previous year she had a very light bulb bright endometrioma in that ovary. And once they start to have malignant changes, they start to lose that bright signal. Oftentimes the shading we see on T2 or the darkness goes away from the blood products. And even though we give contrast, we have to do what's called subtraction, where we take away the bright blood products that are in there so we can see the solid enhancing nodule. So again, a young woman who has endometriosis that has endometriosis-associated malignancy. Here's another example. This is a female who had a history of no history of endo, and she had blood in her stools and went for a normal colonoscopy 2 years prior. They did the biopsy. It came back adenocarcinoma. She came for her rectal cancer staging MR, and one of my friends paged me and said, Wendy, doesn't this look like those bowel endometriosis lesions you're always talking about? And so this is a rectal cancer staging protocol with rectal gel and all kinds of things going on that was done at that time. And it does have the mushroom cap configuration and disease extending to the torus uterinus and retrocervical space and all the things we talk about for endo, but it also has all the imaging features of malignancy. So early arterial enhancement, it restricted diffusion, which is something we look for. It has mucosal invasion, which is super rare for benign endometriosis. So no debate about this being adenocarcinoma. But the question was, did it originate from endo? So we pursued it with some additional stains. So it stained positive for ER, estrogen receptors, and PAX8, which stains for Mullerian origin. And then so it was enough to really prompt them to do an excision, because this type of rectal cancer would be a stage 4 disease, wouldn't be treated with surgical excision. It would be treated with chemo and radiation therapy. So we did the excision and it came back endometriosis-associated malignancy. So another example of someone who had both benign and malignant endo in this specimen and elsewhere in her pelvis. We have a paper written on that for understanding malignant transformation of endometriosis that was published again in 2020 in our first special edition. And we have a new paper out in the Journal of Radiographics on postmenopausal endo, which doesn't necessarily have to be malignant. It's under recognized area of study and clinical practice, but also to some of the imaging considerations, which really do often include malignancy evaluation, because we're talking about a disease with chronic inflammation over time. All other factors aside, that is a risk factor for most conditions to develop potential malignancy.
And I think what's really important from the surgical perspective here is that, oftentimes we are taught and trained about endometriosis converting to endometrioid type ovarian cancer in the postmenopause, or for women that have had endometriomas into their postmenopause. But again, we were talking about this yesterday, but I can count at least people with two hands the number of times I have had, and I am a reproductive surgeon, so primarily see a lot of reproductive age women that have had ovarian cancer or borderline ovarian tumors based within the endometriomas. Now, I think it's really important to understand that this is by no means to create anxiety, because it is still rare. But I think it's also important to have that understanding that sometimes the classic dogma that has been taught to us, we are seeing a complete differential of that in our daily practice. And it's probably because we're getting more sophisticated in looking at these images, in listening to patients, which is exceedingly important, and then also making sure that it's continuously on our differential.
Absolutely. And, and that it can be younger patients than typical ovarian cancer is attributed to. So even patients in their 20s and 30s that may have small borderline neoplasms, tiny nodules, these things could be easily overlooked. So now you can decide, fact or fiction, endometriosis can turn into cancer. Point number 3, All forms of endometriosis respond the same way to medical management. All right, I have a special treat for you all. All right, I don't know if you can hear me. Where's your mic?
All right. It'll catch up.
Okay, are you ready?
My name is no. My sign is no. My number is no. You need to let it go. You need to let it go. Need to let it go. My name is no. My sign is no.
I mean, what fun is a game if you don't have any help along the way? So all forms of endometriosis respond the same way to medical management. Let's look at a subtle case, but one that will show you a bit of our practice pattern. So fact or fiction?
Actually, Wendy gave you the answer in a very non-subtle way, but I'm just going to let you guys still continue to think if it was yes or no.
All right, so fact or fiction. So let's look at this. So first of all, the fact that we follow our patients who are on medical management or expectant management can be a little bit different, right? So there's no practice guidelines that are set forward this way, particularly with MR and for deep disease and any kind of like recommended standards. So we actually kind of have a homegrown program just to be sure, of a couple of things. One, that it's not really increasing the operative complexity as far as sciatic nerve or perhaps blocking, ureter and impacting the kidney. But we also want to be sure that there's no malignant transformation or turning into a cancer. And we also want to be sure that it's kind of responding in a manner that we expect it to the management options that are being provided. So I'll tell you a little bit about that. So this is from 22. We can see this is her low rectum, has a big mushroom cap invasive bowel lesion that's going off towards pelvic sidewall and sciatic notch. And this is what it looks like on our T1 weighted imaging that looks for the blood products. So then we fast forward to 23. She looks almost identical. She's having a few more small little glandular foci in this disease here, extending from her bowel lesion, but it's pretty stable. And then all of a sudden in 24, on her medical management, it's not working anymore in terms of the growth. I'm not going to speak to her symptoms because that's a separate issue. So what's happening in the human body and that response may not necessarily correspond to the symptomatic response. But we see the lesion has grown in the bowel more. It has a lot larger cystic change. It's becoming more extensive. And then even on our T1, we see that there's hemorrhagic foci. So whether it's evolved and changed or whether there's resistance or whatnot, I don't know. But we do see a difference, and you can see it yourself and how obvious that looks when there's these little white dots around it that were previously there the last 2 years.
Absolutely. And I think that from the surgical point of view, or when we talk to patients about things, I think there's a few important sort of take homes from here. And I think maybe one of them, honestly, might be even a little controversial. But I think it's still poignant to talk about it, at least at this point. And that's mostly because we know that medical management is not ideal for the care of endometriosis, because when we don't understand what causes the disease, we can't really work towards preventing it or stopping it on a cellular level. So basically, what we're doing with medical management is we're sort of hitting all types of disease with one sort of treatment manner that we have, which is to suppress ovarian function, because we do know that that can be helpful for symptoms sometimes, maybe temporarily, but it could be helpful for symptoms. So I think that that's the controversial part that I really wanted to cover, to say that I still believe that there's a role for medical management for some patients. And it's important to understand that I think for definitive care of endometriosis, it's excision of disease and, in my opinion, followed by suppression. But there are patients that don't want surgery, are at exceedingly high risk of surgery. And then they have these large nodules and disease processes that we see. That doesn't mean that we just say, okay, thank you very much, have a good life. We actually want to keep an eye on these patients, which we do in our protocol. And we actually follow these patients, and we want to astutely see when is it that we start seeing a growth or a change in this disease process. And that's really when we have to sort of do something more for that patient. And also, some of my work in the basic sciences lab is looking at the molecular signature of disease. And really, I think it's important because I understand that, right now we're describing endometriosis as one disease process, but in reality, I think it behaves very differently depending on what flavor of disease one has, right? So the garden variety disease would be more of the peritoneal disease or superficial disease that's on the surface of structures. And then the deeply invasive disease is a completely different category. But also, what's interesting, especially from our work in the immunology lab, is to look at what is the molecular signature or the immune response to deep disease. And when we study deep disease in the bowel, for example, that acts pretty much like colorectal cancer. So if I ran labs and did all types of basic science testing on patients with deeply invasive bowel disease or colorectal cancer, certain type, the garden variety colorectal cancer, the molecular signatures and the way the human immune responds to it is very, very similar compared to, say, ovarian disease, or for that matter, distant extrapelvic disease, diaphragmatic disease. And for those of us that do this routinely, you name the organ and we've seen it. I've seen people with monthly seizures, monthly red eye, monthly nosebleeds. And so, even though they're uncommon, the more we get sophisticated on understanding that one disease is not all. It's very different, and different people have different kinds of disease. I think we are going to further advance the science to understand how do we block your particular disease that might be different from your neighbor 2 doors down that has very similar symptoms, but very different disease presentation or different nature.
Yeah, absolutely. All right, and just to show you another example here, this patient had, maybe a more hemorrhagic or cystic variant, not a lot of solid disease component. She had her symptoms resolved with IUD placement. Again, this is a really rare manifestation to have someone that's just so purely glandular or hemorrhagic as a presentation. All right, point number 4, children can't get endometriosis. Fact or fiction? All right, so this is a young lady at the onset of her menses who presented with pelvic pain, so 15 years old. She has a really thickened right uterosacral ligament, a large hematosalpinx. She has an imperforate hymen, and she has an endometrioma in her left ovary. So pretty advanced endo already at this very young age. This is just to show you the blood products within the fallopian tube and within the endometrioma. All right.
So just as a surgeon's perspective on those young patients, again, it goes back to, is your eye trained enough to look at all variants of superficial disease? And I've been very fortunate and lucky to have been trained by some leading experts in the field of endometriosis, and commonly they've taught us to look at different people in different ways. And juvenile or teenage endometriosis, for example, is mostly vesicular. So they're very clear, small, like teardrop-like lesions all over the pelvis that you can miss at first glance and not even know that there's disease present. Ironically, that disease becomes more apparent if you fill the pelvis with water and do a laparoscopy underwater, because vesicular diseases, vesicular lesions can, with the refraction of the light underwater, can be more obvious. And so there are some tools and tips and tricks to sort of go over a diagnosing disease in our young patients, especially our adolescent population. And another sort of trick or really important point is, in my opinion, anytime there's a outflow obstruction of menses, much like Dr. Van Buren described, this patient had an imperforate hymen, and so there was a lot of backup of blood and then regurgitation of that blood through the fallopian tube into the pelvis as well. And I say that with caution because we know that there's multiple theories of how endometriosis can form, and we still don't know the magic answer. But anytime there's an obstructive pathology that prevents outflow of blood, I have been probably successful in finding endometriosis in those patients 9 or maybe 10 out of 10 times, because there almost always will be some disease that if we look for, we will find.
Yeah, that's a great point, because even like most familial duct anomalies will have some associated endometriosis. It's really common.
And it's so, and actually we're going to publish on this. We have a case series of people that have, there's a specific condition that young women can have where they have duplication of the uterus. So they have 2 uteri, 2 separate cervices. And then sometimes one outflow of one uterus can be obstructed while the other continues to flow. It's called ovira, or obstructive hemivagina ipsilateral renal agenesis. Usually that's present with an absence of the kidney on the obstructed side. In each ovira patient that we have dealt with at Mayo, we have always found endometriosis on the side of the obstruction, but not on the contralateral side, which is again a testament to the physical nature of how that disease progressed in that particular scenario. But what is so interesting and what keeps us engaged in this disease process, other than our patients' experience and their stories and their grit and resilience, is really these enigmas of the disease that it presents with, right? Like we know that for that manner, yes, of course, regurgitation of blood through the fallopian tube on that side would have been the reason for endo. But how can you explain that for somebody that's having monthly nosebleeds? That's somebody that I saw recently with monthly nosebleeds and endometriosis. Yeah. So that's what keeps us on our toes, because this is a very enigmatic disease, as all of us know.
Mm-hmm. Yeah, those are very important points. And of course, it probably relates to the fact that there are multiple etiologies of endometriosis, subtypes, and classifications of endo. So point number 5, severe symptoms correspond to disease severity. This might link to our topic really nicely and lead us in there. So is that a fact or a fiction? If you have bad endo, do you have bad pain?
Bad endo meaning by staging wise or on imaging wise, right? Mm-hmm. I think if you have pain, you have bad endo, period, right? Because that's but so, like for us, bad endo for looking at it or like visualizing it
many
or surgically.
Disease sites, more complexity, so grading it from like mild to severe in terms of anatomic distribution, size of lesions, distortion of the pelvis, all those types of things for us confer disease severity. So symptoms being, pain or other types of symptoms, do the severity of the symptoms correspond to the disease severity? Fact or fiction? So our first case shows, I'll show you here, this is sort of a low posterolateral pelvic lesion that's invading the rectal wall, the vaginal wall, and it has some small fibrotic spicules going out towards the sciatic notch and sciatic nerve. She had very severe sciatic nerve pain. I'll tell you that. And so this is the lesion here in the coronal imaging and then in sagittal here.
I'm sorry, are you seeing our cursor when Dr. Van Buren is going over the imaging? Are you seeing the cursor?
Yes, we are.
Okay, perfect. All right, I just wanted to make sure that we were seeing that.
So that's, it's mainly all that T2 dark fibrotic disease. There's a few glandular foci within that. And then we can see a little bit of the blood products within that. And there's a paper in radiographics that we published on nerve endometriosis. And you can see some enhancement going towards the sciatic nerve. But the nerve itself is not frankly invaded. Case number 2, mild symptoms, very similar distribution of disease. So it's just happens to be on the other side of the pelvis. So this is the left pelvic sidewall, but the degree of bowel invasion is more. It's a big mushroom cap lesion. The vaginal invasion is really striking, and she has frank cystic and hemorrhagic change invading and involving her sciatic nerve. So sometimes it happens like this, where the amount of disease that I see may not necessarily correspond to the symptoms that the person's experiencing. I sometimes see really severe cases, I'm sure you do too, obviously, in the OR, but where you can't even imagine that it must be the most horrific pain ever, but they're completely asymptomatic.
Yeah, we see that all the time. And I think that's really one of the challenges for those of us that are in this field providing care to patients, right? I always tell people that yes, we'll talk about how bad your endo is on imaging and on surgery, but I primarily want to hear from you. How bad is your life? How bad is your routine? How bad is your day-to-day? How are you living with your pain? Because that to me is even more important. So while on one hand, we want to chase disease and we want to excise disease and we want to do all of that, but on the other side, we primarily want to chase symptoms as well and improve quality of life for people. And specifically for fertility, is the only part where we talk about even if you don't have symptoms and you have advanced disease, and I can do an offshoot on fertility as well, but that's a little bit different. But for people that are looking at pain and pain management and their symptoms for this chronic disease process, it can be very challenging. And we can sometimes see people with just superficial stage 1, stage 2 disease that are in excruciating pain, versus we sometimes see with a completely concrete pelvis, we take 8-9 hours chipping at disease and the patient's completely asymptomatic. But we're doing that for fertility. And I think I see a lot more of the asymptomatic endo people because we address that more for fertility versus for pain and just general well-being. But we still don't understand that very well. And of course, the common things are common. If it's invading a nerve or a big nerve root or something, you ought to be in more pain. But we meaning science is still unable to answer why the disease severity or stage of disease, for example, doesn't go hand in hand with disease symptomatology. Usually does, but sometimes you can be completely thrown off by that.
And on the flip side of that, if you have either negative imaging or mild disease, but severe peritoneal level pain, I feel like perhaps the lack of understanding out there about that degree of peritoneal pain can put people at a disadvantage because that's not well known.
Absolutely.
Right.
And I think that would resonate with a lot of our patients too, right? Because how many times are you told, oh, there's nothing on imaging, I don't think you have endometriosis, let's keep moving forward, right? Let's look at bowel, let's look at your bladder, let's look at other things. And I think that the way we want to really talk and address to patients in that scenario is really to say, I'm not sure. I don't see anything on the imaging, but could it be missed? Probably. And if you have very minimal disease, it could be missed. I know one thing for sure, and that is you're not making your pain up, because nobody that I know really pretends to be in pain just for fun, right? When people come to us with pain and with symptoms, they truly mean that. They would not be in our office traveling hundreds of miles, waiting months on end to see us just for something that they're not truly experiencing. And so that's one of my pedestals, really, is to make sure that we can acknowledge and really empathize with our patients and appreciate that they are in pain, and really be honest with them and say, I don't see anything on imaging. I will do a laparoscopy and we will look to the umpteenth degree for disease. Please know that I may or may not find disease, but if I don't find disease, we still have to talk about how to deal with your pain. It's going to be really important. And sometimes that is the case. And sometimes we do. And what further complicates things is if we sometimes see superficial or minimal endo and we excise and remove it all, patients are nicely suppressed, but their pain is still there, right? And that's still really important to talk about, because what pain, I talk about pain as nothing else in traffic and nerve fibers. And, if it's not endometriosis per se that's triggering those, is endometriosis the cause why your pain fibers are not constantly firing, even though we've removed disease? Is it because they're irritated constantly? And that's where we're going to hopefully going to be getting more information, and we're needing more help with how do we manage patients where maybe it doesn't go hand in hand with disease severity, and we removed all disease and patients are still in pain. I think that's going to be a really important area as well.
I think there is somewhat of a precedent too in other diseases that are inflammatory, like Crohn's disease, where the anatomic disease severity and the symptoms may not correlate. So there kind of is an understanding in the inflammatory disease world that this can happen. And who knows, maybe there is some similar.
Absolutely. And I'm going to say something controversial here that people might like, but I always say if Crohn's was a female-only disease, we would probably also have the same prerogative as we have for endometriosis. Oh, it's nothing, right? But because we still have gender biases, and I still strongly hold on that, and I will fight to the death for that, because in women's healthcare, you have to. Yeah. And it's really important for us to still continue to advocate for our patients, and for patients to continue to advocate for themselves in those scenarios.
Absolutely. All right. Oh, bonus question time.
Ding, 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 ding.
All right. Okay. This is, Duroc knows exactly how uptight I can get sometimes when people start to make inflammatory comments that bother me. So I'm going to give it to you, and you can decide if this bothers you or not. So reducing our delay in diagnosis will improve outcomes in fertility. This stems from a general statement that was made that said that who cares about endometriosis and the delayed diagnosis because it's a benign disease with no treatment. So that upset me. So I thought I would put a bonus question in where we could discuss at least one particular aspect of that question, where we talk about reducing the delay in diagnosis and will that improve outcomes in even just one aspect of terrible outcomes that are the result of the disease, which is fertility. So I'm going to show you an example. I've seen many, many cases like this. So a really common pattern with obliterated cul-de-sac, bowel disease, uterus invasion here of the myometrium, fixed retroflexion of the uterus, kissing ovaries, diffuse adenomyosis, bilateral large hematocsalpinges, and super large ovarian endometriomas that compress or obliterate the follicles. So, that's why I get a little bit upset when I hear these things, because I feel like if people could just see the things that I see, they wouldn't make these types of comments. Because wouldn't it be nice to identify this sooner in the process, before it's so advanced, before all the organs are so impacted, and really there's so much destruction. It impacts not just the pain that we were talking about before, but people's hopes and dreams and family planning.
100%. I couldn't agree with you more, because this is the world I live in. I live, breathe, and eat and live and sleep this every single day. And I strongly believe in an ounce of prevention is a pound of cure, right? Like, it's just, if we can catch people earlier in their fertility journey, gosh, how nice would it be? And Dr. Van Buren is not kidding. This is a Monday morning. Like, this case is like an 8 a.m. on a Monday morning. We see this all the time, where patients constantly tell us that they've been in pain, they've had painful menstrual cycles, they've had 2 years of infertility, they've gone to an REI. The REI has talked about fertility treatments, and sometimes they would be in endometrioma, and despite that, they're continuing to talk about IVF and Clomid IUI and this, that, and the other, yet we're avoiding conversation about endometriosis. And I will be very honest with you, before I was very blessed and privileged to get more time to do my second fellowship in endo and work with people, like Dr. Sinervo and others that are huge names in the field and understand this, I too was scared of endometriosis. It is a scary disease for a general OBGYN with the current training that we have. And really, I don't, sometimes I can understand the perspective of the fertility providers, because an IVF cycle could work for a patient with advanced endo. But the question that I ask is that just putting a Band-Aid, or is that just getting her to a goal of a pregnancy, but not getting her to a goal of a pain-free quality of life question?
Mm-hmm.
And so I, much like Dr. Van Buren, strongly believe in the fact that we, especially in the fertility world, I see this a lot, where patients with still advanced bulky disease are pushed towards fertility treatments rather than endo treatments, in the hopes to basically enhance their fertility. Now, again, I say that with caution, because not one size fits all. And especially in these big formats, I always follow that up, because things can be taken out of context. So, for example, if I do see a patient in their late 30s, early 40s with significantly diminished ovarian reserve, where I know if I did surgery, the right surgery for her for endoexcision, I'm going to tip her almost to a point where she may not respond to IVF medications. Could we do IVF cycles first and do embryo banking, get insurance in the bank on that fertility, and then do surgery, reduce disease, reduce that inflammation, and optimize fertility with embryo transfers afterwards? Absolutely. And that's why that one size doesn't fit all. And just for those that are interested in reading, myself and one of my colleagues, Dr. Aaron Carey from UNC, are coming up with an editorial for the Green Journal about these questions, about what do we do when we're treating endo for pain? What do we do when we're treating endo for infertility? And what do we do when we want to address both, right? And one size almost never fits all. And that's what makes this very interesting and challenging as a provider as well to deal with.
All right, so this again just shows what that posterior pelvis looks like, with bilateral ulmas, an obliterated cul-de-sac, deep disease, bowel invasion. All right, sorry, let's move on. So this is again just showing more fertility, dilated tubes, adenomyosis. All right, number 6, bowel invasive endometriosis is always definitive on MRI. And I mean, like, best protocol, best radiologist you could have. Is it always definitive? Fact or fiction? So I'm going to play you a video here. So this is a pretty common appearance. So there's disease there at the posterior uterus. It's pulling in the bowel, and it's focally thickened. It's not just tethering it. There's some actual bowel wall thickening there. And we've got some hemorrhagic blood products there at that level. This is where we see that kind of beaked appearance. This is where that wall thickening is. It's not our classic mushroom cap sign that's definitive. It's not just superficial serosal tethering. It's somewhere in between. So these are some bowel prepped ultrasound images that shows you the disease at the uterosacral region and the torus uterinus behind the uterus. And then this kind of takes a close look at the bowel there. And this is, again, a bowel prep patient. What is it actually doing in terms of the depth of invasion? And for small lesions like this, you can see it's like 3 millimeters in thickness. It's not going to be quite the same thing as those big mushroom cap lesions for, typically speaking, small lesions, but there can be some long, sticky lesions too that have some degree of thickening. So it's really kind of about the shape and the morphology. So that's number 6.
Absolutely. I think surgically speaking, it gets a little bit challenging when we see these like long sticky lesions rather than a concrete mushroom cap lesion, because we are restricted with how much bowel to remove, and of course the length of the segment can really have an impact on functional outcomes post-op as well. And it's cases like this that one of my morning rituals is gratitude. In this case, believe it or not, you're in my gratitude ritual every morning. And this is a reason for why my radiology colleagues are a part of that gratitude ritual, because I'm lost as a surgeon without their knowledge and their sort of keen eye to guide me. And I think that further goes to show a few things. One, I think first, I think all surgeons should have humility. So a surgeon with an ego probably is not a safe surgeon, in my opinion. But I think what it also goes to show is that endometriosis, and especially complex advanced endometriosis, is a team sport. You can be the best soccer player in the world, and you can still not play alone against a team. And I really, really, really strongly believe in that. And a key member of those teams are our radiology colleagues that give us, these guys are our eyes and our ears and our vision before we enter the OR. And then their interpretation and their reports further is a guide map for us to look for that treasure or gold or disease, right? And then even intraoperatively, there are some complex bowel lesions or ureteric things that I would have to really have my colorectal and urology colleagues involved with. And so this is, again, what makes this such a unique area of medicine, where, you know, the sum of each part makes it that much stronger and really that much more seamless in delivering care for our patients.
That's such a good point. And what you've mentioned about humility is just super true for endometriosis, because it's a really complex disease. And if you are going to be learning something about it, you have to always be humble, because that's how you gain more knowledge base, and you can, you know, kind of learn where the weaknesses and strengths are and keep modifying your practice in that manner, which is what we have the luxury of doing when we do interdisciplinary work. So it's fantastic. All right, number 7, we're going to have to really power through the last 3 points because of time. So bowel preparation is not necessary for a dedicated endometriosis ultrasound scan. It's a slightly controversial fact or fiction.
We love controversy.
We do love controversy. They're fun, right? That's where the questions are. So, you know, I mean, sometimes there is no right or wrong. There's 2 rights or 2 wrongs. Both could be possible, or somewhere in between. So, you know, this is an example. These are all going to be images from the same patient. Now, she does have some, you know, kind of an S-shaped configuration to her uterus. So when we follow like the endometrium, it's kind of like folding back. So you see this, and it comes right. So imagine like an S or question mark. But we have a pretty good look at her posterior compartment, and there doesn't look like there's any obvious endometriosis there. We are scanning through her anterior vaginal fornix. And then she went to MR, and on here, her coronal sequence here, so this is one ovary, this is the other, containing an ovarian endometrioma, which has blood products in it there. We have this solid nodule here that's located in the retrocervical space, and it abuts the bowel, and there's some thickening there. So then we do the MR-directed ultrasound, because that falls into that category of like, we can't just tell for sure on the MR exactly the depth of invasion, but we can repeat the ultrasound, and she's bowel prepped for this, so there's not a lot of gas, and you're taking a look again at a really small lesion, 5 or 6 millimeters here, and its relationship to the bowel wall and the depth of invasion. It's going to be tricky. It's going to be hard to find in a non-prepped bowel. So I'm not going to be dogmatic about it one way or the other, but I'll tell you what my preference is. My preference is, if you're going to ask for the kind of detail where you're going to see small things, if you're going to see uterosacral disease well in its entirety for the course of the uterosacral ligaments, and if you're going to be evaluating for depth of bowel invasion, it is very, very, very beneficial to have a bowel prepped ultrasound. And I would not want to make a decision for surgery on something that wasn't bowel prepped personally. So that's how I feel about it. And I read a lot of ultrasounds. It can be really frustrating, and people are variable, in terms of how much bowel gas they have. But in general, we all have gas in our bowel.
Absolutely.
All right. Pregnancy cures endo. Fact or fiction? I mean, everyone will be walking around pregnant all the time. That was true. I mean, like anecdotally. So I'll show you an example here of decidualized endometrioma. So this is the fetus here inside the gravid uterus, and we see the classic light bulb bright endometriomas with the shading, but oftentimes when they decidualize, we see very similar signal intensity here to what the placenta is. So we know that these are decidualized omas. They're bilateral. They're almost kissing back there. Just as a safety caveat, malignancies can also occur in pregnancy, hormonally sensitive ones. So we do want to be cautious, particularly, if it's an endometrioma that we haven't identified in the past prior to pregnancy. So follow-up is key. These regress postpartum. But again, we want to just keep our minds open to the possibility of aggressive, hormonally sensitive malignancies in pregnancy.
Absolutely. I think we've come a long way to avoid these blanket terms, right? Like, oh, get pregnant, it'll cure your endometriosis. I hear all the time, right? And I think that yes, majority of the times, pregnancy is a really good suppression tool. Like, I think it's probably the best medical management for endometriosis. But of course, you're going to have deviations of the norm. Nothing is 100% or absolute in medicine, and we have to keep our eyes and ears open. But again, it all comes back down to, in my opinion, if we just start listening to our patients. We just have to continue to listen to our patients and what they are telling us. When in doubt, ask the patient. That's always my mantra. If the patient's not feeling well and if she's pregnant, her endo is not suppressed. I guarantee you, if her pain is continuing to go on.
All right, 9. Adenomyosis externa is different from endometriosis. Very controversial. Fact or fiction? I mean, this is the kind of thing that at conferences and meetings we could go on and on about, and there would be no winner at the end of the day. I'll preface it with that. However, I will show you what I see and why I believe what I believe. So we see here that there is adenomyosis externa. There's some glands here, but also the back of the uterus is folded back a little bit. And there's usually like a nice little cleft here, and that's filled all with this stuff here. And then when we take a look at the uterosacral ligaments, they're thickened at the torus here. So there's deep endometriosis. It's invading the bowel, and it's all in continuity together. So the glands in the stroma outside the uterus we call endo. But then if we take out the uterus for hysterectomy and it's section of pathology, and they see the glands and stroma in the myometrium, they're going to call it adenomyosis on pathology. So really, if you can see the images and know that it's coming from the outside in and the patient has endo, it's probably all in continuity and deep endo invading the myometrium. So I think maybe some change in terminology could be beneficial so that we can properly categorize adenomyosis and do research around it.
I 100% agree, because, and this may not present with your classic adenomyosis symptoms of heavy bleeding, low back pain. This just might present with just endo pain and chronic daily pain, whereas adeno could be very cyclic and pretty much related to your menstrual cycle too. And the other really important reason of why we need to understand these differences, which we, by the way, still do not know, meaning science, as scientific communities, we still don't know the differences, but it'll be really important because it would be nice for us to counsel patients about their fertility status. We know that adenomyosis markedly impacts implantation and fertility, and we know that there's certain things that we need to do around fertility treatments if the patient's getting those, or embryo transfers, but we still don't have any idea of endometriosis coming from out to into the wall of the uterus. Is it the same as the adenomyosis, which almost starts from the junctional zone or the cavity and then goes into the wall from the cavity out? But this is out from the abdominal cavity into the wall of the uterus. And so those differences would really help us in managing and giving prognostics to our patients.
Absolutely. This is an anterior example. We won't go into too much detail. So we can get to 10. We have a gold standard in endometriosis diagnosis. Fact or fiction? So to help you with this, I'm going to show you a radiology image. that shows of the arrows here, deep disease coming from the left uterosacral ligament, which is the orange arrow. And there's a huge bowel invasive sigmoidal lesion here with that mushroom cap shape involving the entire sigmoid colon. This was residual postoperative. There's another endometriosis nodule anterior to the round ligament there. So this is an example of where, even though we sometimes refer to surgery as the gold standard, there can be significant disease, whether it's due to lack of identification on preoperative imaging or surgical technique or training on both sides of the equation. And this is what it would look like intraoperatively with the adhesions. You can imagine it would be hard to see. And then superficial disease. So here's a case where, again, the radiology imaging is normal. I'm not going to say there's something abnormal here if I don't see something abnormal. There's no abnormality here for me. And we see what Dr. Khan was speaking about before, these small vesicular lesions that were not seen on the MR. So we see kind of both sides of the equation where there can be, there really is no gold standard. We have no definitive test for endometriosis. There are always going to be a portion of cases that are missed one way or the other.
Totally agree. I call it, we don't have a gold standard. We may have a gold plated standard, but not a gold standard, right? And I commonly see this, and I see this from some very experienced surgeons as well when patients come after surgery to us. And that is no discredit to them, because if I did surgery, I would probably say the same thing. But it's colleagues like Wendy and her group, when they look at these and help us identify and look at these patients from a radiologic standpoint, that augmented with then surgery, I think combined could have a role in making sure that you are not missing any disease that could be hiding in plain sight. So I think that surgery is great. I think imaging is great. I think they're both essential, but I think that they may be parts where one is lacking and the other compensates for. So it's almost like complementary and augmentative than anything else.
Absolutely. So like superficial disease for surgery, deep disease for imaging. And then so if you have both of those together, you've got your best case scenario. All right, so that brings us to multidisciplinary conference. I'm not going to go into too much detail, so we have time for some discussion here, but that really is critical. And we did have a huge change in patient management, almost 20% through interdisciplinary conference, and that's published as well in abdominal radiology. So it's a complex disease. I really strongly recommend dedicated MR and ultrasound protocols. They're excellent for disease detection. The interdisciplinary work is key, and really to consider MR for the workhorse for upper abdomen, nerves, lateral compartment, liver and diaphragm, and extra ovarian malignant degeneration, as well as post-op complications. So now the International Endometriosis Imaging Congress. This is going to be March 8th and 9th, 2025. It's our inaugural meeting, so it's around the corner. And we have CME for radiologists, gynecologists, sonographers, and MR technologists, nurses, and primary care providers. So there'll be 2 dedicated tracks over 2 days. So one that's more introductory and another one that's more advanced. However, there's going to be a lot of interdisciplinary collaboration. Dr. Khan and I will be there. We have a mixture of gynecologists, radiologists. We have a sonographer speaker and a nurse practitioner. And it's really going to try to show you the whole gamut of imaging and how to incorporate that into your practices in a really detailed manner. We are going to also have some exciting hands-on sessions. So I'm excited about that with simulators for ultrasound so that you can become accustomed to what the scan techniques will be. We're going to have a team of people also coaching through live scanning in their own cases with you. And additionally, we're going to have a hands-on AI session that is going to show you how upcoming tools in AI could help you with some of these complex interpretations as well. So it's going to be an exciting meeting. I personally am extremely excited for it. I feel like I've literally been waiting for this my whole life. And if you're at all interested, check us out, scan the QR code, browse it, keep us in mind this year or next, or whenever it might be the right time for your practice. So we're really grateful to have a chance to share everything that we're doing with others. If you have any questions, reach out to, he's not going to want all your emails. You can reach out to me.
Happy to receive. It's last name dot first name. So it's fairly simple. Last name dot first name at mayo.edu.
Social media as well. Any of those places are great places to reach out with thoughts or questions or feedback.
Excellent, 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 excellent.
Thank you. Thank
Wonderful.
you.
We have a handful of questions. Do you have time to answer?
Sure.
Absolutely.
Okay, our first question, which was sent in over Instagram, MRI versus ultrasound. I mean, this in itself is a whole hour. Pros and cons.
All right, so we just finished putting together a systematic review in the American Journal of Radiology. It's called a best practices article. So if you have access to medical literature and want to look that up, it compiles literally all of the studies that met strict criteria from around the world and took a look at ultrasound versus MRI for detection of endometriosis. And so that gets into a lot of nitty-gritty details on practice environments, resources available, and disease sites. But I will give you the synopsis in my personal opinion. Number one, you should get the imaging that is available to you and where the most expertise are available. So something is better than nothing. And if you live in a center where there's a lot of high level ultrasound being done and that's the resource and go-to thing and expertise, go ahead, have that. If it's MR, then go ahead and have that. If you are in an environment where you have access to both, which a lot of communities in the United States are fortunate enough to have access to this, sort of one of, I think, a great model is having the Society of Radiologists ultrasound augmented routine pelvic ultrasound as an initial measure. So doing the sliding sign maneuver, posterior cul-de-sac evaluation, it's not bowel prepped yet, but can really assess a lot of features that suggest endometriosis, and that in combination with clinical symptoms could then prompt having a more detailed mapping exam. And those could be done most commonly with MRI with types of protocols that we showed. And it really gives you, in my opinion, the most comprehensive of all the disease sites. It does particularly well with lateral compartment, nerve, and areas that might be obscured by bowel gas or technical limitations of ultrasound. And then if you're going to surgery and want some further finesse or refinement, there is a certain category of bowel lesions that could benefit from an MR-directed ultrasound. But that's kind of like the pie in the sky. That's what you do if you have all the resources available to you, but there are many, many options along the way for what can be done and do a good job.
But I think what's important, at least from the surgical perspective, and I hope you would agree, because I haven't talked to you about this ever actually, I don't think all MRIs are made the same.
No.
Right. And all ultrasounds are definitely not made the same because they're heavily operator dependent.
Right.
So much like surgery, I would even go out as out to say that, like, much like surgery, it really matters on who's doing your ultrasound and who's reading your MRs and what protocols you're using. Because I continue to learn from Dr. Van Buren every time I meet with her, but really, I think that you would be surprised to sort of even see that if Wendy's on vacation and somebody else reads something, I might have a completely different sort of opinion when I talk with Wendy because I have a sort of a spidey sense about something not being there and there's something that's missing. So I personally think it matters a lot on who is doing your ultrasound and who's reading your MRs as well.
And another variable with that is, because like anything, yes, it is, with time and experience, we do learn and we learn more and more, refinement. The equipment also matters.
Yes, the equipment.
So, I will say that's not everything, but it certainly is important. Like if you're using ultrasound equipment from, I don't know, let's say 10 years ago or something, it's definitely not going to be the same as ultrasound equipment that's from the last couple of years. Likewise for MR scanners.
Like a 3T or something.
Yeah, exactly. So, and again, preferences and availability and access, these are two different things. So, I may have my preference with things, but that doesn't mean there aren't other good options out there that can do things well. I would just encourage, for people who are involved with their own practices to optimize the resources that you have. Obviously, we're not going to go out and buy new MR scanners today for most people, but, we're going to, what we can do is optimize our protocols, take a look at some of the really technical parameters, the field of view. It's going to be very similar to rectal cancer, where you want to have a really small field of view to see the peritoneal deposits and some of the level of detail. If you're scanning a whole pelvis MR, I see this unfortunately not uncommonly, something that you would see for like MR enterographies or large field of view pelvis. It's not going to have the level of detail that you need. You have to think of it like zooming in. It really only acquires data from a very small area, and that's kind of what you need as a fundamental aspect to endometriosis MR scanning. So it's not just the sequences or the equipment. It has to do with a lot of those technical parameters that we try to share in our publication so that people are able to replicate it as much as possible.
Okay, I have another question.
That was long. That's a big question, Sally.
We try to teach that the notion of endometriosis is not viewable on scans is ending, obviously, because how far out do you think we really are from like the average person on the corner in their local hometown getting the right read and the right care that they need?
So,
It's a theory question, you know, like
it's something that, yeah, I mean, I'll say I feel like it's not imminent. It's not going to happen next year or 2 years from now. It's one of the reasons why I started the Endometriosis Imaging Congress. It's because it's one of those things that, like, I wish that people could all have access to this type of imaging. This is the standard of care that I believe should be available to everyone. But before breast imaging has managed to do this with like a lot of uniformity through, federal regulation. It's law.
Yeah,
right?
that's true.
It's law.
I
It's
think
the only area of imaging that's law, actually, and so endometriosis patients, I'm not saying that we need to go this way where it's legislated, but it's something nearly that, where you need to make sure that there's protocols and standards in place, and that there's the education to actually carry it out. So, you can set in place standards, but unless there are educational resources and tools to accomplish them, you've asked for an impossible task. And then you need to really educate, even from a fundamental level, all radiologists and all gynecologists, let alone primary care as well, and layers. And so where we're at for education, I will be completely honest, is we're at subspecialty level of education on that pyramid.
yes.
We are at, fertility doctors and AEGL MIG surgeons and a subset of fellowship trained abdominal radiologists. We need to expand this to be at the next level of, we need most general radiologists as well as abdominal radiologists to perform this well. We need all gynecologists, general gynecologists, to understand this concept as well in these exams. Then we need all primary care to understand this, all pediatricians to understand this. I mean, so where are we? Like 10-year plan? Is that, and I'm an optimist, but I think that just doing this for the last 10 years, the growth is slow until there's momentum through patient advocates such as yourself and others who've been really pushing the gamut in the last year to year and a half. This makes such a difference because the voice has to come from the population that are wanting this and needing it. Unfortunately, like I could be screaming in a dark room, literally, in my radiology reading room, and no one's going to listen to me. I could say, like, look at all these women who deserve so much better, so much sooner. And I'm just one lone voice that really no one cares to listen to much, but it requires like 10,000 voices. It requires more voices, and it requires, action.
And it's very complex, right? I mean, I think it's a grassroots movement. It starts with our educating our medical students about it, right? Like I tell you, I saw somebody yesterday that has been on interferon for 5 years because they thought she had inflammatory bowel disease, and this person actually has endometriosis, right? And so when you see this happening in 2025, it just sort of makes your skin crawl, right? It's just, it has to be, and this is why we love what you do and what your colleagues do for creating that grassroots movements that augments our efforts, right? But you're absolutely right. I think it's, and I truly believe that legislature has to be involved in this too, because like, the reason, I mean, Sally, I did 10 years of training after medical school because I wanted to be that one-stop shop person in order to give patients sound advice about their fertility and endometriosis. We do not have a system for a doctor to get that training till they spend 10 years of training and come back with a head full of, no hair or white hair, but you take your pick, right? Sort of a thing.
Well, and not that many people after they make it through medical school can give 10 years because they have to start earning back.
Circumstances happen. Yes.
We were in the family business is medical school education, which another time. I think it would be interesting, while I have you, I think it would be interesting to have you talk to Representative Gilchrist, whose sort of specialty is language in legislation, because why not, like you say, oh, well, you have an idea. That protocol could be the same as the breast cancer protocol.
Right.
Yeah.
I
So I had so many
Yeah, a vision for this, you know. I mean, I do think we should have endometriosis imaging centers of excellence. That's literally the
True.
model.
And endo-associated infertility centers of excellence.
Yeah,
We're treating endo-associated infertility the same way, and that same way as IVF each time. And I'm a fertility doctor. I love IVF. I think it has done wonders, but not one size fits all.
Yeah. So next year, Dr. Khan has committed to a session with Dr. Bebahani Siddiqa they're going to do a session IVF and endometriosis, and probably Dr. Gargiulo will join you for that session. But
Great
we're
person.
already planning that, and you know my dream. You don't know my dream because I'm putting it out to the universe now is we should hold your imaging congress and the endometriosis summit concurrent.
This would be awesome.
You could be in really, especially your Saturday, Sunday, you could easily be in lecture halls and we could be in different lecture halls because ours on Saturday is very patient oriented. So we wouldn't take the MDs away from you because I'm looking at your program and you have so many. First of all, Megan's going to spend all of March on a plane.
Yeah,
Right?
she
only comes for 24 hours. So she's on a plane a lot.
Yeah.
But you have also Dr. King is another good one when you talk about medical school curriculums. Her work with Harvard, she is doing work with endometriosis and getting it into the curriculum. And there's a lot of like networking. And I do believe that we have a responsibility as advocates to make everything spread a little bit. We have to pique interest. We have to challenge these days legislatively. We have no idea what's going to happen, but
Right.
we have to start the conversation. We have to encourage even going to and it was very hard. I tried to do it for our lab too, even going to the tech schools and having the radiology techs as students that they would be interested in the lab. We would be happy to give it to them, but then the school wouldn't give them off.
Mm-hmm.
We have to push for the importance of this, I think.
Absolutely.
Absolutely.
Yeah, no, this is great. We should discuss this more because I think that's a great idea.
I'm really I'm down for it. And then next year we're going to talk about receptiva or mapping. Because all the time I get asked, I had the receptiva. Do I really need the mapping before surgery?
Yeah.
Yeah.
We need 2 hours minimum.
I know we need 2 hours. So hopefully you will. Well, look, we're looking forward to the future. Your conference is March 8th through 9th, 2025 here in Miami, Florida, which you can see the hotel from my terrace on the 25th floor. So we will wave to everybody. I'll be there. Don't worry.
I'm a little jealous right now. I'm not going to lie. You know what it is outside here? It's like, what, -9?
It's a balmy -12.
Yeah.
My assistant is in New Jersey, and I asked her in our meeting this morning how it was, and she said that she thought it was in the teens. And my dad heard, and he laughed in the background. Yeah. I mean, I did skip pickleball this morning because I had a lot of things to do. But tomorrow morning it's tennis, right? 7:30 a.m. But it's a great life if you could live it, Miami. So
great exercise.
Right. Well, then in the summer I'm on the Jersey Shore on the beach.
Yeah.
Amazing.
Yeah. So, but we should talk about collaboration more. I do want people just tell everybody your social medias to reach you.
Sure. Yeah. That. So let's see.
Oh, you're gonna put this slide up again.
But
yeah, I can put the slide on.
Yeah, and it's for the meeting. It's at Endo EIC, which is literally Endometriosis Imaging Center of Excellence, which is the concept that I want people to start thinking of.
What do you think about we could do like a little virtual patient we could do these slides again, patient based in Miami.
Yeah, absolutely. What are you like
I
this
don't know,
year?
we'll think about it. Well, yeah, like you remember AAGO this year, we're very grateful. They did like a little patient based, it wasn't long. But it was nice to see so many MDs be at something like that.
Yeah, absolutely. Yeah, tell me more about that too, because I don't know if I
Sometimes it depends on what your CME level is. Like there's a certain level of CME that then you're required to do patient education. It's not just, I mean, AAGL does want to embrace the patient voice, but some of these teams, they do it just because in order to maintain their CME status, they have to do it. So.
Oh, well, I would be a big fan of including any type of patient education. That would be fantastic.
Yeah, you and I will just be on the Instagram live. It'll be great.
Okay, perfect.
All
That sounds
right.
amazing.
So we remind everybody that we are live with the Endometriosis Summit March 28th through the 30th, 2025 after your conference. So next year we want to do concurrent.
That's
and
awesome.
we'll even step it up and go to the Conrad in Orlando so that we're at a really nice hotel. So and we will be back with you next week on Monday. We want to thank our guests from Mayo so very much because it's 9. That means it's 8:15 and they're still sitting in their office. They're not home.
That's true story.
That is true. Yeah.
And I think we're going to be here for another 2 or 3 hours. We were just like,
I have work to do. Yeah. I did a grand rounds on endo imaging for Chicago this morning. So
wonderful.
And then interdisciplinary conference at lunch and then MR for endo all day. So I mean, you see what my life is. It's literally
I know, but that's what it sort of takes to get it done. You know, if you didn't want to do if you didn't commit to all that, it wouldn't be a 10-year timeline till it's everywhere. It would be like a 30-year timeline.
This is true.
Yeah.
Sometimes I just pray that things happen before I die. No, I'm not joking. I mean,
yeah, there's a line in there. Dr. Fogelson is a huge Star Wars fan. So there's a line in Andor, which I am also a Star Wars fan. And they talk about how when you start a revolution, you're not going to live to see it through. And so I hope that that isn't true, but you know, we do what we plod for it as fast as we can anyway.
True. Yeah,
Absolutely.
It's true. We can only do the, our best really, so it's really amazing though when we find other people who feel similar passion, and the more that we group together like this, I think it's fantastic, and spread the word, and people, these fact or fiction, these myths, these are real discussions and they are complex issues. And so I think it even means more to me to have a chance to have fun with it, but to also get to talk about some of these challenging things, because sometimes it's the controversies that create barriers, when really we want to take the controversial things and have them be the root for our next steps, for our science, for our research, and to like push forward our clinical practices. So
totally agree. And I think most importantly, these are people's lives, right?
Yeah.
These are lives and these are people's sort of experiences that we're talking about. So I think that when people say the thing that irks me the most is when people say it's a benign disease. Yes, by definition, it's a benign disease, but it's anything but benign because it seeps into every facet of your existence. And really, I see a lot of patients with pain and just significant infertility, and then just seeing their lives change through process of treatments, which may or may not be an ideal treatment for fertility or pain, but any change in their lives is impactful nonetheless. Because when I started this, I always wanted to win every single case. Every single patient I wanted to get pregnant, every single patient I wanted to get pain-free. The reality of life is you're not going to get there, but you're still going to be impacting every single patient's life when you truly connect with them and truly explain to them what they are facing and what's going on in their body. I truly believe that makes a big difference in people's lives.
I think we also have to define what is a win.
Right.
Truly.
For years, I used to go to, now the demographics of conferences have changed, but of course we all remember being in the old men conferences, and they defined a win as patient being pregnant. And I was never able to get pregnant. And so I don't consider myself as someone who didn't win. I don't consider myself a loser. So I think
because you're not.
Right. But that's a whole other conversation. And the patient community does lead that, but that has to infiltrate our academic areas and our societies. What are we defining win? And also what has to infiltrate the patient's areas is pain-free is sometimes a myth, because that's not the win either, because there's a lot of life to be lived between pain and pain-free.
Very well said.
Yeah.
Yeah.
Very well said.
Right.
All right, for the 6 people that are still on. All
Yeah.
right, we're gonna chat. I'll see you guys soon.
That's
Absolutely.
great, Sally. Thank you.
Thank you for
See
this
you.
opportunity.
Take care. Good night.
We'll talk
Bye-bye.
soon. Bye-bye.